Today's speakers include Ed Gaudet, CEO and founder of Censinet, and Dr. Larry Ponemon, the chairman and founder of the Ponemon Institute. Again, thank you for being here. I'll turn it over now to Ed.
Thanks, Heather. So we've got a lot to cover. We got a lot of data. I'm pretty excited to be here with Larry today. Good afternoon, everyone. We're going to cover, obviously, the research findings, and we think about it in two contexts. The problem, and the metaphor we're using is this tip of the iceberg. And then really what was revealed through the research, or the bigger problem. And we're very excited to share that with you today. And then we'll wrap up with some recommendations, and then we'll go through the Q&A. And so before I turn it over to Dr. Ponemon to go through the research instrument, let me give you some context for why we did the research and why we partnered up with the Ponemon Institute. So I've spent my career working with some great teams, automating workflows through software. And specifically, the last decade has been focused on healthcare. And as a vendor to the healthcare industry, I personally experienced the pain of having to manage thousands of risk assessments. And today, my team and I, we speak with, on average, 20 CIOs and CISOs in healthcare a month. And here are some of the trends that we hear are challenges for our customers. We see and hear the trend of outsourcing, the need to move business processes and applications to the cloud. Providers tell us about the tremendous pressure to modernize their clinical engineering and innovation strategies and programs, and specifically with the use of internet-connected devices such as medical devices and other IoT devices. They've also been tasked with emerging technologies and applying those in the pursuit of gaining efficiencies such as machine learning, AI, and obviously blockchain for more security-related initiatives. But we also hear loud and clear the mantra of do more with less. There's tighter budgets, there's limited resources, and specifically when you look at areas of security, we hear that the effective unemployment rate of security professionals is 0, and sometimes in the negative. So providers are finding it very hard to attract and retain talent in IT and in security to drive and provide support for these initiatives. And obviously, the business of every health system is to deliver care, quality care, to its customers, patients like you and me. And part of that is making sure that providers have the resources and technologies they need to provide the highest quality of care and the best care. So with that, we captures, obviously through this conversation, lots of data and anecdotal information about these challenges. But we wanted to understand them and how broadly they applied across the industry by working with Dr. Ponemon and applying statistical research and analysis. So with that as a backdrop and as context, I will turn it over to Larry Ponemon.
Thanks, Ed. It's always a pleasure presenting with you. And I know we have a long history of doing some really good research. For the rest of the presentation, folks, I'm going to serve as the research wonk, which I really like because I am a researcher. And Ed, you will be the subject matter expert. So feel free to chime in at any point in time in the presentation. Is that a deal?
Sounds great.
Okay. Remember, I'm holding you to that contract.
Okay.
Now, a little bit about this study. It's a really good study, and again, I'm somewhat biased because we did the study, but I think you'll find that the results are very powerful, and the quality of the results are very significant, but I'll talk a little bit about that. In total, we have 554 IT and IT security professionals in healthcare companies involved in managing their organization's vendor risk management program. We abbreviate that by VRMP. All organizations represented in our study have a VRMP, a vendor risk management program. Now, again, some of these programs may be ad hoc, some could be very formal, some could be early stage in terms of maturity, some could be late or very late stage. So there are differences, obviously. Just saying you have a program in place doesn't mean that you win, the golden triangle, whatever. But for the most part, we have a very good, well-experienced group of individuals who are involved in VRMP. Now, in terms of where these people are located, if you look at the left-hand side of the screen, respondents by operating structure, we have 29% of our sample that are located in a hospital or clinic that's part of a large healthcare system. Then we have integrated delivery system, which is 26%, network, which is 17%, standalone hospital, which is 16%, and the smallest slice of the pie, standalone clinic. So, you know, we're dealing with a number of organizations that could be very large in terms of number of beds to those that are relatively small, modest and small, but we do cover quite a bit of variation, which is another interesting aspect of the results. Okay, now if we turn our attention to the right-hand side of the screen, this is respondents by department or function. Because we really aimed at trying to understand VRMP from the IT and IT security perspective, the largest slice of the pie at 32% would be information technology, followed by clinical staff, followed by patient services, then compliance, procurement, medical informatics, risk management, legal, record management, human resources, privacy, and just about everything else. So even though the majority are in the category of clinical staff or information technology, if you look at the pie, some of the slices are very thin, but it's very interesting because we have a very diverse group of practitioners. So anyway, let's go to our next slide.
Yeah, I would just add to this, Larry. I think the distribution is fantastic because not only on the operating structure, but on the department and function. And this is what we've been hearing too from our customers is that IT and third-party vendor risk is not an isolated function. And it does cross across many different departments and many boundaries and does touch and affect many of these departments and functions that we have listed here today. So it's good that we were able to survey these types of folks and get a much more balanced response about the impact.
Yeah, I'm glad you emphasized that because diversity in a sample is very important. It has its pros and cons. The pro is that you sometimes see patterns that you would not otherwise see if you were more limited in your scope. But that's the positive. The negative is it's very hard to build a sampling frame that covers all of these territories. That's our competitive advantage as a research company. We're really good at doing it, but it's a labor of love. We love research. Back over to you.
Yeah, so I think I think for us the one of the major takeaways, and this won't be a surprise for many folks, but the number of third-party data breaches that were related to that happened over the last 2 years, and then the average cost of those third-party data breaches. So, and Larry, you just did some recent work with IBM on the overall cost of data breaches. So I'd love to get your perspective given this data.
Sure. Well, we just completed our annual cost of data breach study, which we've been doing, it's hard to believe, for 14 years. So we're in year 15. It's a lot of years, a lot of pulled out hair in the head or white hair. But the bottom line is we actually have some interesting data that supports the data that we have in this study. So for example, in our study here, the average cost of a veteran risk management program is a vendor risk management program is $2.9 million. The overall cost that we calculate is about $3.9 million for healthcare as a whole in our study. And we basically find that the number one cost in terms of per capita cost per lost record, the most expensive is healthcare by a long shot. It's like $429 for every infraction. And I know when you think about how bad this can get, I know it's not healthcare, but Facebook had a $5 billion fine imposed. So, I think our government is just waiting for a big, juicy healthcare company to come along and have a big data breach and pay a huge fine.
That's a great point. Yeah, and in fact, I track the OCR portal on breaches, and we're halfway into the year already in 2019, and there are actually more individuals affected so far in 2019 than were affected for all of 2018. So the trend lines just don't seem to be slowing, and which is amazing given the investments providers are making in security technology. So you would think you'd start to see some leveling off, but the attackers are getting much more sophisticated, and the attacks are getting much more costly.
That's been our experience as well. Our research all supports that. One point that's kind of interesting is that, as organizations spend more resources, more money on security technology, instead of seeing a real improvement, we see an increase in cost. But in part, it's because the organization is now able to see it. Many organizations have been living a life of bliss, ignorant bliss, where they say, well, we haven't heard about it. We don't know if we have this problem. We probably don't have it. In reality, the bad guys are just lurching, ready to roll in organizations that are unable to, identify and then contain the data breach. So we don't want ignorance is bliss. That's never a good thing.
Yeah, I think you're right. And the more they do get a handle on the problem, we start seeing trends around the average, as an example, the average number of vendors that are under contract. I would say about a year ago, that number was lower. But with the push to outsourcing and cloud adoption and medical device adoption, that number is increasing, and it's almost doubled from the numbers we had just under a year ago.
Yeah.
So at 1,300 annual on average vendors under contract, and only 27% said they assess all these vendors annually.
I thought that was quite amazing. That only 27% say this has a halo effect, right? People are more likely to say, oh yeah, sure, I do it, and they don't really do it. So 27% is probably an overestimate of what the true percentage is. And you don't want to brag about 27% saying they actually assess vendors annually.
That's right. That's right. Any other data you want to touch on this slide?
Sure. Well, we basically have, and we'll talk about it later, but if you kind of look at who's doing VRMS or vendor risk management programs, we basically see about 3% of the 3.25 or 21 full-time employees who are fully dedicated to completing the vendor risk assessment. That translates into about 513 direct hours spent monthly completing assessments. Look at the average number. You mentioned this before, but over 1,300 vendors under contract. That is a large amount of information to control. 53% say their organizations allocate an average of 17%, about $2 million of the cybersecurity budget for VRMP. Respondents estimate it costs an average of $5 million to implement all 4 controls, which we'll talk about a little bit later. 40% say vendor risk assessments are very valuable, so that's good in terms of providing actionable insights that can be reported to the C-suite and board. And then 42% say these assessments are somewhat valuable in providing information on what actions their organization should take. So, the issue of audit, normative types of issues in that 42%. So these stats suggest there's a lot that's going on in the healthcare organizations that participated in our study.
Great.
You want me to tackle this?
Yeah, go ahead.
Okay, well, I love your input on it too, Ed. So these are some of the findings, and this one is like unbelievable. 76% of a sample, no matter what it is significant. So current risk process are costly, inefficient, and don't reduce exposure to data breach or downtime. 76% believe that to be true. Scary. 59%, another pretty high percentage here. Senior executives and business owners are permitted to go around the vendor risk management process, do an end run. 59%. We know that's bad, but we do it anyway. And notice that it's to management, the higher levels of management have more leeway. And then 54%, which is not jump change, it's a fairly large percentage. Health systems are at risk of a data breach because they are unable to complete risk assessments of all vendors. Remember, we had that, I think it was 27% in our last slide. So these percentages suggest things are just not working very well, my friend.
Yeah, and this maps nicely to the narrative that we see talking to providers. They are using spreadsheets, they're using emails and phone calls to manage this process. It's highly manual and ad hoc. And in order to keep up, given the volume, they have to continue to throw resources, people at it, which obviously is not sustainable or scalable. So what ends up happening, one of the adverse effects of that is that the people that they support, the clinicians, the administrators, the heads of operations, need those products and services to do their jobs and support their overall strategies and operational objectives. And so they end up going around the process, which makes sense, right? And then when what ends up happening is IT gets a call when there's a machine or an application that needs to be connected to the network or the internet, and that's when all hell breaks loose. So the data supports, again, the anecdotes that we've seen, which is great, but it's a bigger problem than I think even our customers imagined.
Yeah, agreed. Okay. You know, and this is a good slide. I'll present it, and then maybe you can interpret the results, because I
Sure.
think some really cool things in this slide. Firstly, you need a better set of eyeglasses. The font is a little small. I apologize. I'm talking for myself. I'm not trying to criticize anyone who wears glasses. I need them, probably on magnification like 400%. The importance and effectiveness of vendor risk management control practices. So these are the 4 control practices that are fairly generic in most organizations. Data breach and cyber exploit response procedures. The blue bar is importance of the vendor process, and that's 86%. It's important, very important, essential. That's a big deal. The red is effectiveness of this particular control. So 86%, hey, this is important, but only 33% say it's done effectively or it's effective.
Right.
Let's look at the other 3, right? Prioritization of vendor risk, 80% important, 36% say that they're able to do this effectively. Enforcement of non-compliance with security requirements, that's a big deal. 72% say, hey, this is important. 39% say it's if they're effective. And then finally, assessment of regulatory compliance, 71% say, hey, this is really important. 34% say, yeah, it's important, but we aren't able to do this effectively. What do you think?
Yeah, so these gaps are huge, and again, I think it screams the need for automation. And so I know we're going to talk about that in a little bit, but yeah, the data really supports the need to get a handle on these processes and really start to apply automation and some more mature processes to solving some of these and closing some of these gaps.
Another point about this slide too, before we go on to the next slide, is when we basically look at a response like how effective, that's the red bar, that's normally a halo effect question. In other words, people tend to overestimate because we're asking them, how good are you in your job? And we basically still get some very small percentages. So the true percentage, if you kind of had to adjust for the halo effect, is probably lower than what we present here, which is interesting news. Yeah, I know.
Mm-hmm.
Next slide. Okay, perceptions about third-party vendor risk. Now here we're using an agreement scale from strongly agree to strongly disagree. And if so, there are 5 choices, and we're just presenting the strongly agree and agree response combined. That's what each percentage is. So the statement that we're grading here, an increase in investigations and fines from Health and Human Services and OCR due to deficiencies in vendor risk management. Strongly agree response at 66%. Current manual risk management processes cannot keep pace with cyber threats and vulnerabilities. 65% agree or disagree, or excuse me, agree or strongly agree. In other words, it's believed to be true. Current manual risk management processes cannot keep pace with the proliferation of digital applications and devices. 63% agree or strongly agree, or basically see that it's true. And then third-party risks are reported to the board of directors. So 34% believe that to be true, or 66%, the other 2/3 do not believe it to be true, which means we're probably not reporting to the board, which is a really important control. What do you think, sir?
Yeah, again, this ability to keep pace with the pressures from OCR, the fines, and then again the drive to do more with less when you're getting hit with these cyber threats that are changing on a regular basis, and obviously will change as new applications and devices are brought in and connected. And so the threat surface is just exponential, given the evolution of how a health system actually manages and implements systems today. So, yeah, I think it continues to be just a huge problem, and it as the data shows, Larry, it's not getting better; it's just getting worse.
Yeah, it's true. So now this is perceptions about vendor risk assessments. Again, we love that strongly agree to strongly disagree. So we're using the same format that we used before, strongly agree and agree response combined. So time spent on vendor risk assessments takes resources away from important tasks. 60% believe that to be true. It's kind of a depressing result because isn't risk assessment an important task? But he's kind of assuming here that it's less important than other things. Required under HIPAA to annually assess the risk of third-party vendors. 60% believe that to be true. Regulations mandate that every healthcare provider identify, assess, monitor, and mitigate risk caused by third parties. 58% believe that to be true. Inefficient risk management workflows that rely upon spreadsheets, emails, and other manual processes are automated to save time. That's an interesting percentage. 44% believe that to be true. And quite frankly, I'm a little bit surprised by that number. We'll talk about that later. Then 100% of vendors are assessed annually. Remember that famous 27%, that's it. 27% believe that to be true, or 73% do not believe that to be true.
Yeah, and that annual number and that annual assumption is something we talk about again with our customers because 10 years ago, applications were mostly on-premise in the data center, controlled by the health system and the IT organization. And today that's changed, right? So most of those applications are either outsourced or on their way to becoming outsourced and hosted in the cloud. And a cloud system changes daily or has the ability to change daily. And so what was done and completed as an assessment is pretty much out of date the minute it's published. And to wait a year to actually reassess those cloud applications and devices that are constantly getting updates, really I think is provides sort of a false sense of security and protection, and really needs to be rethought and discussed openly because again, like I said, the attack surface has changed and the frequency of change has increased exponentially than it was just again 5 to 10 years ago. So that notion of annual assessments, I think, will go away over the next 3 to 5 years, based again on the technology and the ability for the technology to change much more rapidly than it has been in the past.
Ed, what concerns me is our medical devices, the ones that you wear, or even worse than that, ones that are implanted in you surgically. We've done some research that tries to determine what organizations are doing to ensure that these devices are well managed and secure, kept safe and secure for the public. We found that there was many organizations said, well, the testing is done by the manufacturer, for example, and the manufacturer would say, wait a second, we're not responsible for testing this. That's the healthcare provider or the client. And so as a result, there are all of these people with implanted devices that may not, be that safe, or may actually create security, even privacy risk. So
That's right.
And that's a risk that was not even on anyone's radar screen 8 or 9 years ago. Who an implanted medical device? That was like a science fiction movie. So they're changing.
That's right. And even 10 years ago, medical devices just were, if they were connected, they were segmented properly and securely on the network. And today, now they're obviously connected to the internet, and they're connected to, as you say, consumer devices. So again, that problem is exponential, and the attack surface is exponential. Yeah, there's a lot to say on that topic alone.
Oh, I know, it's a big topic. Okay, this is my favorite topic, the cloud. Yes, the cloud and internet increase third-party risk, which is probably not too surprising. Again, the strongly agree and agree response combined. 72% say healthcare providers increasingly rely upon third-party medical devices connected to the internet that are inherently risky. We just talked about that. 72% believe that to be true, which is pretty high percentage. 68%, not chump change, that's a good high percentage as well. Moving to the cloud while connecting medical devices to the internet creates significant cyber risk exposure. And I know that from some of the other studies that we've done on cybersecurity, that the companies are very vulnerable when they're migrating to the cloud platform, like a hybrid cloud. And third-party vendors account for the majority of all data breaches experienced. And this is right at the cusp here. It's 50%. In other words, one minus that or 50%, I do not believe it to be true. So it's kind of in the middle.
Yeah, that's right. And, you know, the interesting part of this, and it's kind of a nice dovetail into the last point, is when you think about risk data and to devices, there's really two major attack types, if you will. You could have data loss through a breach or an extraction of data. And then you can have disruption to care or operations, maybe through ransomware or some other outage, either malicious or unintentional. And when your data is breached, obviously as a consumer, it's an inconvenience, right? And it could be embarrassing, and it can cost you time and money and effort to kind of get your identity back and all of that. And many of us have gone through that, including myself, and it's painful. But if your dialysis machine is hacked or intubation is disabled, this could result in death. And I think that's a much more concerning risk in light of the trends to connect applications and devices to the internet and to rely more and more on the cloud. So I think, you know, we're just again scratching the surface as it relates to data breach results, but also disruption to the business and to patient care in general.
Yeah, agree completely. Okay, so again, strongly agree and to strongly disagree and agree and strongly agree, response combined. So again, not completing all vendor assessments puts organizations at risk. Yes, 59%. Senior executives / business owners are permitted to go around third-party vendor risk assessment process to secure a lucrative business relationship. Wow, 59% believe that to be true.
Mm.
And 54%, our organization is at risk because we are unable to complete risk assessments of all of our vendors. So again, that's another way of looking at the 27%. This is now 54%, which supports 27%.
Yeah, and we showed these 2 points earlier. So these are really, really particularly interesting and concerning statistics, which obviously as an organization and as an industry, we really need to focus on and tackle.
So this is a cool question. A lot of choices here, of course. Which function below benefits most from a well-functioning vendor risk management process or program? And the number one, the winner of this, the clinical department. And 75%. This doesn't add up to 100%, folks, because you could select 2 or even 3 or 10, whatever. 3 being kind of like the goal. Clinical departments, followed by procurement / purchasing, followed by compliance, then legal, risk management, the CEO or COO, the CFO and finance, the CISO or CSO, CIO, CTO, a lot of C's, and board of directors at only 8%. So again, it's the whole gamut. And my guess is that it makes sense that the clinical department would benefit the most because, you know, a vendor relationship that results in improvement to patient care, that's a really good thing. Procurement thing as well. Yeah.
Yeah, that's right. And this is again supports what we see when working with health systems as well. And if you look at this next slide, it's kind of interesting because again, you see what vendor types pose the highest risk, and you see clinical applications and the clinical research program, as well as obviously the cloud providers. So again, everything we've talked about supported through this data. Anything you want to add here, Larry?
No, but it does line up to the previous slides, like clinical applications, cloud providers, clinical researchers, applications and developers, and so on. They're all different types of vendors, and in fact, they're all probably pretty important. Even if there's a low percentage, maybe they're more narrowly defined in the organization, but they're still very important.
That's right. That's right. And I think what's also interesting here is that the question posed was vendor types, and obviously some of these are third party related, but you also start to see that internally developed applications and processes are also being represented here. So, you have back office applications that might be built internally. And so the need to assess an internal software development lifecycle process, or let's say you have a relationship with a physician practice, and so you see affiliated practices also here being represented. Clinical researchers, obviously, are 47%, and that does represent a process that includes, collaboration between different covered entities, like maybe an academic health system or a pharmaceutical company, obviously patients, et cetera. So that's an interesting, unique, and pretty complicated and complex business process that does require that assessment of risk. So what we're finding is that third-party risk is sort of the tip of the spear. There are other areas within a health system that also require the same level of rigor and discipline when it comes to assessing risk.
Very cool. Thank you. Next slide. So this is the percent of respondents that would remediate or terminate. So there are actually two separate questions here. So let's go from the left to right. Respondents that would mitigate or remediate the security gap. In other words, basically to win the relationship with the vendor who cuts some slack here on having to comply with security or data protection or even privacy requirements. 33% believe that to be so. And the right side, a lower percentage even than 33%, 28% say respondents would terminate a relationship with a vendor if the vendor didn't comply. So that means 1 minus 28%. So if my math is correct, that's a large number.
A large number, indeed.
A large number, indeed. So, and that's a depressing finding too, because basically if a vendor is not qualified to do whatever it needs to do in your organization, it's probably true in every other organization. So someone is paying the bills or dealing with the negative consequences of a vendor that's not able to comply with reasonable standards.
That's right. That's right.
Okay. The percentage of vendor assessments that result in disqualification or require to remediate. These numbers are remarkably low. 21%. Third-party assessments that result in a requirement to remediate prior to doing business with them. 21%. And that's 11%, which is shocking. Third-party assessments that result in disqualification prior to doing business with them. So of 100%, 11% are basically said, you're unable to work for us because you are disqualified. That's kind of a depressing place to be as a vendor. Any comments here, Ed?
No. I think this is spot on, Larry, and again supports the previous data that we've seen.
Thank you.
And now this is the slide that really starts to move from the tip of the iceberg, if you will, to really what's underneath and the bigger problem. And this was the data that I found shocking, and when we started to connect the dots between the anecdotes that we heard from our customers and the providers that we speak with, it made a lot of sense. So do you want to set this up, Larry?
Sure. So if we start from the left side and move to the right, unable to keep pace with the proliferation of cloud apps, connected devices, and threats and vulnerabilities. We basically know that an organization might have hidden costs, direct costs based on process inefficiencies, whatever. And we know that that number of the cost or time can be 10 times the direct cost of basically these hidden costs that we're talking about here or showing in the iceberg. So when we look at things like, what does it cost us to do X, Y, and Z, say from a vendor compliance perspective, there's a direct cost, people who might be directly responsible for the program. But there's also a very large group of people who are touching the process, even though they're not directly dedicated to it. And we calculate that as about 10 times the number of direct assets. So the true cost sometimes is missing, right? Because all of these indirect may not be part of your costing or investments evaluation process. And the end result is they're largely ignored, but they are really big costs, especially in the healthcare, because everyone is in a healthcare environment. You have many professionals, doctors and nurses and others, and basically they are very good at what they do, and they could be touching the vendor or third-party relationship in what they do.
Right.
You want to finish the analysis?
Yeah, sure. And again, what the data shows is that they they need more resources, they need more budget to get the job done. So um, there's a 2.5 times gap between what they have in terms of investments and resources to what's actually required to do the job. And so we find that given that people take shortcuts, people find ways to work around the budget limitations, and obviously that increases the risk of of disruption or breaches that we talked about earlier.
Very nice. I love that graph, by the way. I'm gonna, if you don't mind, I'd like to plagiarize it.
No problem.
It's a good metaphor for what we're talking about here. Okay, so this table is probably the readers are members of the security community. They're looking at these numbers and saying, "Oh my God, is he going to go through every one of these calculations?" And the answer is yes. No, I'm not. I'm not going to do that. I'm not. This is in the report, by the way. So in the report, you get to study all of these numbers all over again. But what we try to do is determine the direct versus the indirect costs. The part of the iceberg that's above the waterline, which would be like your direct, and below the waterline, which is your indirect. And for direct, we start with the number of FTEs who are dedicated to vendor risk management. And for our sample, so we have some large organizations, some smaller organizations. So an average of all of these would be about 3. I think it's 3.21. The hourly capacity of dedicated full-time equivalent per week is 128. And you can see the other relationships. Then if you scale it up for the year, you basically have a fairly large number of hours of the dedicated staff, I think over 6,000. And lo and behold, we then look at the number of registered hospitals in the US through the AHA research, American Hospital Association statistic of 6,210. And then we just multiply it out, total direct hours for the industry, not just for one company, is 38 million plus. That's a pretty large number. And then fully loaded, this is if you look at doctors, nurses, all sorts of people in the organization, it comes out to about $63 based on some of the benchmarking that we've been doing for years. And so the annual direct labor cost to the hospital industry as a whole, the direct cost is about $2.4 billion. Almost the Facebook fine, by the way, which was what, $5 billion, but now it's a huge industry effect, $2.4 billion.
That's right. That's right. And it's even worse when you look at the hidden costs.
Oh, yeah. Let's go to the hidden cost. Wow, look at that number. But hopefully no one fell off their seat. My goodness. So here we start with the total hours per month expended by not just the people who are in risk management, but everyone in the organization that touches the third-party relationship. And that's over 5,000 direct and indirect labor cost hours in total. Then the total hours per year expended by all employees is over 60,000. Number of registered hospitals, we see that again. And then the total hours for US hospital industry per year is $375 million, if I'm doing that correctly. Wow. Fully loaded cost, that's at $63. And multiplying that out, we get $23.7 billion. Again, that is a huge, huge number. And so there's a real cost to not just the individual organization, but to the industry as a whole, healthcare industry as a whole.
Yeah, and that's tremendous impact economically to the industry.
Great. And if the audience, they think we made a mistake or we could have done a better analysis, I'll tell you what, if you can do it better, I'll pay you $1. I'll bet, okay, $2.
I don't think anyone wants to take you on, Larry.
Oh, I'm glad. That's good.
You have too much experience.
You're right.
All right. Let's go to the recommendations.
Good. So a new way, less time and cost. So the research that we've conducted, and a lot of these percentages will show you when you read the research report. It's pretty clear. But there's time savings as a result of having a better vendor risk management process, that does all of the good things that we said it should do. and avoid all the bad things. We don't need an ad hoc process. We need a formal process, for example, but to focus on high value tasks such as training, scenario planning, continuity tests, and so on. That ultimately leads to improved security posture, and that saves time. You want to tackle the 10%, 10x?
Yeah, again, what we see is that, given everything we talked about, providers obviously can't keep up with the volume. And so what ends up happening is there's a bit of an artificial stratification of risk to assess, critical or high vendors. And while I think this process is important to do, I think also sometimes, it's really hard to know what vendors pose the highest risk and critical risk just from the surface. And so obviously there are two ways to think about this at a macro issue. You want to make sure obviously that any vendor that manages and processes protected health information, PHI or PII, which are covered by the regulations, that they get assessed regardless of whether they're perceived low, medium, or otherwise. And then there are vendors that they may not be protecting PHI, but they may be the weak link in the system, and that's the challenge you have as a security professional, obviously, because that weak link is the link that will get exploited by the hackers, right? They're going to attack the easiest the way in to your organization. And sometimes that might be with a vendor or supplier that is perceived as low risk because they're not managing PHI, but in fact, they're the springboard into the attack. So we think, if you're automating those processes and you have a much more mature process, and we'll talk about that in a few slides, then there is a path to providing the ability to assess all vendors. Obviously, you don't really care about toilet paper or some of the other items that are needed in a health system, but clearly, if an HVAC system has the ability to connect to the internet through an IP address, then obviously you'd want to take that into consideration. So. We believe that automation provides the ability to increase that overall coverage. And again, as I mentioned earlier, not just do it once, one and done, and worry about it from an annual frequency, but actually have that continuous ability to monitor the updates that are provided by the vendors throughout the relationship or contract that the health system has.
Nicely said, Ed. And the other cost issue here is reduce costs 50%. But we firmly believe that by having the right program in place, again, avoiding the concept of an ad hoc or loosely defined set of activities, the one that's more formal and structured and has specific objectives, and aligning those objectives with business objectives and clinical objectives. Doing all of that will result in a cost reduction, and especially around hidden costs, the kind of the part of the iceberg below the waterline. Data breaches will be reduced, never totally mitigated. There will always be a data breach problem, but it can be managed to the point where it's not a big problem or a high risk. And also disruption of patient care and overall business issues in healthcare can be improved upon, thus resulting some very substantial costs.
Great. Thank you, Larry.
Thank you.
And so we would suggest that a way to handle this is through an automated process and application. And really the way to do it is through a collaborative risk network. What this means is connecting the provider community with their vendor community in a way that provides efficiencies that folks have never seen to date. Things like the ability to quickly search and find the appropriate application or vendor that is in the system and may have already been assessed by another provider, and through a one-click assessment, be able to get that data almost immediately. And because it's obviously automated, there are abilities to provide visibility and reports to the clinicians, so and other operators in the health system, so they can see at any given point in time where their request is for assessment in the process. And then lastly, this notion of continuous monitoring and updates is important. And if you think about it, and from a vendor's perspective, they're inundated by hundreds of assessment requests a year, or more, given the number of providers that they may be dealing with on a monthly and on an annual basis. And it's really hard to get ahead of that from the vendor perspective. We know that I tried in the past. We created operations from a sales perspective. We hired people. We tried to create knowledge centers. But the challenge is that every provider asks a different set of questions. Now, they may use frameworks that are available, but the frameworks like, say, NIST, provide ambiguity in the way questions could get answered or processed. And it's really been difficult, I think, for vendors to kind of stay ahead of that. What we would posit is if there's this collaborative risk network, then that information can be created, managed, stored centrally, and then shared across the network with providers on an as-needed basis, giving the vendor control to share that with the right set of providers, but also give the vendor to go back, the ability to go back at any point in time and version and update those assessments or those questionnaires that are used in the assessment process with documented evidence, additional changes in questions or risk posture. As an example, let's say that the vendor didn't have a SOC 2 report at the time of assessment, and 3 months later they were able to finish up a SOC 2 report. And so by attaching that to their overall profile and questionnaire, everybody on the network would get that update that they're connected to. So those are the types of advancements that have been made in this area, whether it's Censinet or another vendor that provides a similar set of requirements or functions and features. This is the way that, I like to tell providers, you're going to do it this way eventually, whether it's with us or somebody else. This is the way to do it longer term in order to get ahead of all of the data that we just talked about, all the trend lines. There needs to be a substantially different way, a much more process disruptive way of tackling the challenges with third-party risk management. So we're excited about the partnerships we have with our providers and our vendor community. And we would obviously, if you're interested, love to talk and share more about what we're doing there. And then lastly, and I think, any advanced third-party vendor risk management organization or vendor will talk about a maturity model. And we do as well. We think about a maturity model from a provider's perspective. And we see most providers today are either ad hoc or in this managed phase or stage. And ultimately, folks want to get to a much more dynamic, real-time and dynamic state or maturity. And so we provide, obviously, not just technology, but the process and the resources to enable this. So we've seen a lot of really great outcomes that support the percentages that you talked about earlier, Larry. And again, we're very excited to be presenting with you today, Larry. And with that, I will open it up for questions.
Thanks, Ed.
Thank you, Ed. Thank you, Larry. Everyone, please feel free to type questions into the Q&A panel of Zoom. And if for some reason we can't get to your question live during the webinar, we'll be sure to follow up with you afterwards via email. So we do have a couple of questions that have already come through, and we'll start with the first one. Can you talk a bit about how VRM applies for data controllers versus processors and how organizations should think about it, especially in the space of IOMT software connectivity platforms?
Wow, that must have been a CTO who asked that question. So let me take that with the disclaimer that I'm not a technologist. I don't not a I don't program, I don't develop, but I do know enough to be a little dangerous. So as we talk about what a controller is versus a processor, the way to think about it for folks that may not be familiar with these terms is that when you sort of have a device and there's a purpose for that device in specifically how it might manage PHI, for example, right? And then the processor is the thing that actually does processes the data on behalf of the controller. And usually that processor is a third-party component or external company. And there's a lot that's being talked about for GDPR specifically in this area. As it relates to IoT medical devices, what we've seen in the past is this has been really self-contained. The device contained an embedded operating system, and from a security perspective, the medical device provider would complete the MDS2 form from a manufacturer's perspective, stating that basically the profile, the security profile of that device itself, and oftentimes that device would be shipped, obviously pulled out of the box, and then configured based on the requirements of the provider. Those devices rarely got updated. In fact, many manufacturers would sort of resist the updating, and it would obviously affect warranty, as an example, and or security. And so with devices today, what we're finding is that it's much more complicated because now they're connected, obviously, to external processors, such as a cloud application, or a workstation that may be connected to the cloud. We think that, and we see this with the folks, the NEMA and the HIMSS organizations that curate the MDS2 security forms on behalf of medical devices. We believe that there'll be changes there that are coming in the next couple of months that'll start to talk more about this particular area. But what we find is that the vendor risk management process cannot just look at a medical device as a blob or a single object. It needs to take in consideration the different aspects or modules of that device and the application or use cases of each one of those modules, and assess each one independently, but also look at it on an aggregate basis. So, we look at that as a trend moving forward, and we think that tools in this area need to obviously take that into account, be able to support the MDS2 manufacturer-oriented assessments, but also the ability to assess each one of those modules that it is being used by the provider. So hopefully that answers that question. Let's go to the next question.
Excellent. Why is the emphasis on assessing all vendors? They're not created equal. Shouldn't proper risk stratification focus efforts on assessing and mitigating higher risk vendors with significant dependence and higher likelihood impact, not vendors that get 2 purchase orders a year for non-essential products?
Yeah, I think I talked about that a little bit earlier, and I don't think it's necessarily that binary. Like I said, there are ways to sort of do a stratification, if you will, of risk across your third-party vendors, and I think that folks should do that anyway. But I wouldn't advise necessarily. First of all, I think any vendor that is processing PHI should be assessed as critical or high, and then I think that artificially assessing a vendor without actually looking at it and actually getting going through the assessment process and pulling in data and having a conversation with the vendor, I think just is troubling and could potentially cause more problems than the ease of not assessing it affords one. So I think it's important today to look at all vendors. We've certainly seen instances where that stratification has happened. We've done the assessment, we've done the rating, and the provider was actually surprised at the rating, called us on the carpet. We looked at our algorithm, we looked at the questions, and in fact, we were the assessment was correct. They went back, they talked to the vendor and realized, wow, they were risky, and they didn't realize that they had mobile applications that were being brought into the health system as part of their overall solution. And they were deemed high risk, and they actually had asked the vendor to go through remediation and mitigation efforts before they brought them in longer term. So we just think the notion of assessing risk before artificially and stratifying into buckets might be necessary, but it's certainly not sufficient long term.
Excellent. We just have time for one more question.
Okay.
And if we weren't able to get to your question today, don't worry, we'll answer your question via email. So one of your slides said that automation could reduce hidden costs by 50%. Can you explain that number?
Well, probably automation. I'd love to hear your opinion on that 50%.
Yeah, sure. Again, what we find is that because of the nature of what folks are doing today, there's a lot of manual steps that go into and efforts that go into coordination, collaboration, communication of the process across different groups in an organization. And as again, anecdotally, we saw this, and we also saw that our customers really wanted to reduce not so much the cost, but they wanted to really provide much more visibility into the process. And as a, sort of as a result, that reduced the unnecessary manual steps such as phone calls and emails. And we have one provider, CISO, that gets called, in the middle of the night from clinicians to find out where their assessments are. So, I like to joke and say risk never sleeps. Well, clinicians never sleep either. And if you're on the receiving end of that, it's better to provide the ability for those clinicians to get access to and visibility of that process at any point in the process. So obviously they don't go around the process, but more importantly, they're not spending time trying to chase CISOs or IT directors or risk analysts with answers. So we see, based on the automation and based on the ability to route workflows and route approvals through the system, a significant reduction in time that it took previous to the automation being applied.
Excellent. So thank you so much, Ed and Larry, for your time today. And thank you, audience. We appreciate that you've joined us. We will send everyone the recording of today's webinar as well as the report, and we'll answer any questions we couldn't get to via email. Thanks again.
Thank you.
Have a great day.
Thanks, Ed. Thanks, Heather.